Hello, everyone, and welcome to today's CLL webinar brought to you by the HealthTree Foundation. My name is Meg Heaps. I'm the CLL Education Manager at HealthTree. I'm very grateful to have each of you here today and for your support in building the CLL community. I'd like to let you know that today's session will be recorded, and the recording, along with any resources we discussed today, will be sent via email to all registrants within 48 hours after the event has concluded. We'll start with a brief Zoom meeting tutorial for those who are new to the platform. We'd love for all of you to turn and keep your cameras on if you feel comfortable. Doing so helps us create a stronger sense of community. With that as well, you should see on the slide how to turn on your camera. At the bottom of the screen, you'll see the microphone and camera buttons. You can click on the video icon that says Start Video in order to turn your camera on. With that being said, if you're not comfortable being recorded, you're not required to keep your camera on. Your microphones should be currently off and will be kept off by our team throughout the presentation. During the group discussion, you're welcome to unmute yourself once you're called upon. Oh, and I believe I was sharing. Let me just double check. Okay, yes. If you have any questions or comments for us or for our speaker throughout their presentation, please click the chat icon and type them in the chat box. If you're using a mobile device or a tablet, click the three-dot icon that says More and then Chat in order to access the chat box. And lastly, if you would prefer to ask a question or make a comment directly to our speaker during the discussion time at the end, we encourage you to do so. If you're using a laptop or desktop computer, click Reactions near the bottom of your screen and then click Raise Hand. If you're using a mobile device or tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. Now let's get started with today's event. First, I'd like to thank our sponsors who make events like this possible, AbbVie and Genentech. The topic of our event today is fixed duration versus continuous duration CLL medicines. Here's the agenda. I'll introduce our speaker, Dr. Alvaro Alencar. Dr. Alencar will then spend the next 30 minutes or so giving us his presentation. After the presentation, we will open it up for your questions and comments. So let me take a moment to introduce our speaker, Dr. Alvaro Alencar. Dr. Alencar is an associate professor of clinical medicine and the chief medical officer at University of Miami Sylvester Comprehensive Cancer Center. He's a member of the lymphoma program at Sylvester and the lymphoma committee at the Alliance for Clinical Trials in Oncology. As the hematology section lead for the Sylvester Global Oncology Program, Dr. Alencar serves as an important bridge to the United States for Latin American hematologists, being a constant presence in meetings, lectures, as well as tumor board and second opinions. These collaborations have led to a large multinational study evaluating the impact of genetic changes and ancestry on outcomes of Hispanic patients with blood disorders. So with that, I'm going to turn it over to Dr. Alencar.
Thank you. Thank you so much for the invitation. It's really a pleasure to be here. I always enjoy talking to CLL patients because it's such a tight community. Patients are always talking to each other and participating in boards and blogs and trying to understand the disease better. So it's really an honor to be here and be able to share a little bit of what we've been doing, what is happening with CLL, and really have a nice discussion on where the field is heading. So I think I will start with a brief history, and it's a short history, but it's an interesting one because it falls right back on where we are today, and this idea of fixed versus continuous therapy. So for some of you with CLL diagnosed quite a while ago, you may recall that in the beginning, we used to treat this disease with combinations of chemotherapy with immunotherapy. And if I can stop there and just remind everyone, I think that one of the biggest challenges that we have when we diagnose one of these indolent diseases, and as you can see, I am a member of the lymphoma program at my cancer center. I am a member of the lymphoma committee at the Alliance, and in the great majority of the cancer centers, CLL will be managed by a lymphoma doctor, because in reality, it's more of a B-cell lymphoma than really a leukemia. It's kind of a misnomer. In some centers, for example, MD Anderson, it's the leukemia team that will manage CLL, but in many centers is really with the lymphoma doctors. Because if you recall, CLL and SLL, they're just really two different takes of the same disease, same biology, same molecular background. CLL is more of a liquid disease with some nodules, while SLL is more of a nodal disease with some circulating disease, but really the same features. And all these low-grade lymphomas have the same idea that you may identify it suddenly. So somebody goes to the doctor or has an imaging for whatever reason, finds a lymph node, biopsy the lymph node, find a CLL, SLL, or as commonly happens, you go over, get a blood check. Oh yes, the lymphocytes are a little bit higher. Look back, they've been kind of highish over the last few years, get a CLL diagnosed, but the first shocker after you are told you have a leukemia is that we're not going to treat you. So I think that it's not an easy first in discussion just to discuss that you have a cancer, that you have a blood disorder that will eventually require therapy, but does not require therapy in many cases at first. And the fact that treating early makes absolutely no difference is really sometimes very hard to grasp. But when we decide to treat, and in essence is really when the disease is causing trouble. We have very effective therapies. We have had very effective therapies. We're expected to have even more effective therapies coming our way. And in essence is if the disease is causing trouble, we treat it. If it's not causing trouble, we don't do anything about it. And we just follow and monitor closely, because exposing you to therapy earlier than what is needed really doesn't make a big difference in the long run. And kind of dragging our feet, we do it on purpose, because by the time we decide to treat, maybe we have even better treatment options. So it's mainly if the disease is causing trouble. If there are big lymph nodes that are causing pain, you're pushing against other organs, that's an indication for therapy. The counts are low, so there's enough burden of the disease that is impacting the marrow function. You have some anemia and some low platelets, that's an indication for therapy. If the metabolism is super high because you have this, feels like this steaming oven that is just so active that it starts just fuming. That's kind of the idea, that the increased metabolism in the background, and you start losing weight, having fever, having night sweats, the disease is too metabolically active, you need therapies. You see that I don't mention the white count, because the white count does not really matter much, if at all. So we know that in some leukemias, the cells are big and chunky, and you don't need a very high count to start having problems with the blood flow. The cells will just start clogging up the blood. With CLL was not really the case. Those are small cells. It's really a small cell lymphoma. It's a small cell disease. So the cells are small, and we're able to really have a very high cell population in the bloodstream without having much issue. So in general, just because the white count is high, I know a lot of times it scares primary care doctors or some other doctors, but the reality is that the white count alone is not really a reason to treat. There is this doubling time thing, which in reality is more of a writing on the wall. If the doubling time starts, so that means that if the lymphocyte population starts doubling in less than 3 months or so, that means the disease is probably picking up pace, is becoming more metabolically active. Probably is a writing on the wall that, yeah, you probably should start thinking about therapy. But in general, the white count alone is something that we just more watch than anything else, and it reflects the burden of the disease to some extent. As you know, some diseases more in the counts, more in the nodes, so we just need to have a general impression of the disease when we're evaluating it. But fine, we decide that you need therapy. What used to be done way back when is that we used to combine chemotherapy with some immunotherapy, and the initial immunotherapy was rituximab, and rituximab was not really a very good antibody for CLL, because CLL just does not express a lot of CD20, so we needed to use a higher dose of rituximab to be able to attack the CLL cells well. But chemoimmunotherapy did a relatively good job. We had bendamustine, we have fludarabine, cyclophosphamide, so those were regimens that we used give for a certain period of time and then stop. And then came the first wave of these pills, and the first BTK inhibitor, ibrutinib, kind of came in, and at first, in the first indications were just for patients that had 17p deletion, so there were some limitations, more higher risk disease. So back then, I remember we used to discuss, you can give finite therapy with chemoimmunotherapy, or you can give ibrutinib. And then slowly things started changing as we started noticing that in reality, these agents were superior to chemoimmunotherapy in every single setting. So slowly, chemoimmunotherapy, bendamustine, FCR, all became not really a major player in the treatment of CLL. So and then came this period when the main agent for the treatment was a BTK inhibitor, especially ibrutinib, and then slowly came venetoclax. So just move forward to today, and today we're back on this idea of finite therapy versus indefinite therapy, but with both regimens not really involving any chemotherapy. So, and where we are today is that the way I describe this to patients is that you have a lion that is coming to attack you. And you can put this lion in a cage. The lion is alive, but is in a cage. It can't attack you. That's the BTK inhibitor. So with BTK inhibitors, we have excellent disease control, super well tolerated, but we never, hardly ever achieve complete deep responses. So the lion is always alive. We always see the lion in the cage. As long as you're taking the pill, it's inside a cage. You stop the pill, eventually the cage is open, the lion comes out. The other is a combination with venetoclax. So venetoclax combined with that antibody, but now obinutuzumab, which is a superior antibody than rituximab, clearly proven to be superior in CLL, is like a sleeping dart. Puts the lion to sleep. So you're able to achieve deeper responses, and you're able to achieve enough disease control that you can stop and monitor. Eventually, the lion's going to wake up. Once he wakes up, you do something about it. So why this difference? Has a lot to do with the way these drugs function, how these drugs will really attack the CLL cell. So BTK is a piece of an important cascade of activation of the CLL cells. So it's from the B cell receptor, which is activated and really makes the cells proliferate and expand and reproduce themselves. So by blocking this, you really kind of block a critical lifeline of the cell. And in addition to that, it kind of removes the cells from their normal niche. So it's kind of like a hostage situation. You have a hostage and you don't want to go inside because you're going to break in. You might kill the bad guys, but you might kill some good guys that are just being held hostage. So what do? You shut the lights off. You turn off the water. And slowly they're going to run out of water, run out of electricity. They'll come out. And it's kind of the same idea. You get the CLL cells out of their environment, and they go from the lymph nodes to the peripheral blood. And by doing that, they're not in their environment. They kind of give up. So you are you're changing the way the cells function, and that's the way you control the disease, but it's not really a killing process like you do with chemotherapy, for example, or with venetoclax. So venetoclax is a BCL2 inhibitor, and BCL2 is closely related to apoptosis or programmed cell death. And when you use venetoclax, you're really targeting that programmed cell death and inducing cell death. So you really have a deeper response. And when you combine venetoclax with an antibody like obinutuzumab, which uses other cells to really attack the CLL cell, you really have a big cell death. That's why you are able to achieve a deeper response and stop the therapy. So in essence, you're just attacking the disease from different fronts and controlling the disease in different ways. So with BTK inhibitors, because you're constantly suppressing this mechanism that keeps the disease under control, you have to constantly take the pill. And so it becomes an indefinite therapy because you need that constant exposure to maintain disease control. And if we look at the data on these agents, yes, over time, you have deepening of the response. So the more you look into it, year after year, there's a bigger proportion of patients that actually achieve a complete response. But it's not really the expectation out of these agents. By themselves, the expectation is you're going to have excellent disease control, but the lion alive in the cage. With the combination of venetoclax and obinutuzumab, it's almost a given that you're going to have a deeper response that will allow you to stop therapy. Some patients will have a very deep response, so you can safely stop it, and it will be quite a while before the disease returns. Some patients may have a good response, but still some detectable disease at the end of treatment. It may come back a little bit shorter. So again, it's a different approach and different benefits from each one of them. You're all very familiar, I'm sure, with the BTK inhibitors, but in general, the class of BTK inhibitors, today we have three main drugs that are used in first line for treatment of CLL. Ibrutinib, acalabrutinib, zanubrutinib. Ibrutinib is considered the first generation BTK inhibitor. These are covalent BTK inhibitors. We're going to talk a little bit about it later. And the other covalent BTK inhibitors, acalabrutinib and zanubrutinib, are considered second generation because they came back a little bit later. And what we know is that mainly as far as efficacy, they're very similar. One of the differences is really related to tolerability, how well they're tolerated. And one of the issues or the main issues with BTK inhibitors have to do with what is called off-target. So by targeting BTK, that part of that pathway that we talk from the B cell receptor, as we target that, we're addressing mainly the CLL cells, but there are some other BTK receptors in some areas. But in addition to the BTK receptors that are off targets like ITK, EGFR, some other receptors that these drugs also end up targeting. And these off targets are related to the toxicity associated with these drugs. In general, they're very well tolerated. But ibrutinib has a lot of off targets. That's why it has a little bit more of toxicities. But as a class, we're dealing with some bruising because it has the same impact on some receptors on platelets, kind of like aspirin. So we have the same, you like put soap on the platelets and the platelets don't stick as well. So you have the same effect as platelets on the platelets as aspirin with a little bit of bruising, some bleeding. Extreme bleeding is described, but a little unusual. And in general, you can even combine these drugs with other anticoagulants if needed. We try to avoid combinations with warfarin, for example, but that's not something that we have to talk right now. I'm happy to talk later about it. But in general, these drugs have one of the issues is bleeding. It has some receptors in the heart, the toxicity, or in the cardiovascular system, so that toxicity is not very well understood. But these drugs can be associated with arrhythmias, hypertension, and ibrutinib does more of that than acalabrutinib and zanubrutinib. It's much less likely with acalabrutinib and zanubrutinib, but can still happen. In addition to that, because of the EGFR, you have receptors in the skin, you have receptors in the gut. Some patients can have some diarrhea, some patients can have some rash. Not so common, not so severe, usually is very well tolerated. Some patients may have some drop in counts, it's not too severe, but the most common recurring issues with these drugs are the arrhythmias, the bleeding, maybe the high blood pressure. Acalabrutinib has a little bit more headaches compared to the other ones, but in general, it's not too far from that. What is the issue then? An easy drug to take, seems to control the disease very well, but the problem is that continuous therapy will have its drawbacks. And one of the drawbacks is that you are exposed to this risk of toxicity as long as you're taking the pills. So the risk may be small, but if you are at this constant small risk, the rate of having major problems are small, are getting bigger over time, right? So there's pretty small risk in crossing the street and getting ran over. But if you keep crossing the street back and forth, back and forth, back and forth for ages, the chance of getting run over is greater. So is the exposure that puts us as problems. And there's some hypothesis now that actually the withdrawal of the drug actually helps prevent development of resistance. So yes, it's very well tolerated. Yes, it's extremely successful, but the drawback from the continuous exposure is really the continuous exposure. But still today, very well accepted as a standard of care, having these drugs continuously. We talk about venetoclax and obinutuzumab really targeting these agents and really killing these cells. And one of the drawbacks of this combination is that it's so effective that we have to be extremely careful when giving it. And what we have to do is that we have to kind of slowly give these doses up until we reach the full dose. So the full dose of venetoclax, 400 milligrams, we start at 20. Next week, go to 50. The following week, go to 100. The following week, goes to 200. Next week, go to 400. So you slowly bring up the dose every week to minimize the risk of what we call tumor lysis syndrome, when this drug is so effective, it melts away the disease, and all the breakdown of these cells can overwhelm the kidney function and really shut down your kidneys. So by slowly bringing the dose up, you minimize that risk. And we have other gimmicks that we can do. We can give just the infusion of the antibody first to kind of cool the disease down before you're exposed to the venetoclax. But all of this requires much more commitment. So you have to be checking labs prior to getting the pills and after you start the pills. So you need to get the infusions. These infusions in the beginning are weekly, then every 4 weeks. So it requires much more commitment. So while with the other agents, with the BTK inhibitors, you pop your pill, you check your labs maybe weekly in the beginning and then monthly and then every 3 months, because it's so well tolerated and so easy, you can start almost in any setting. Get a combination, very effective, but requires a greater commitment from both sides. From the patients and checking their labs and coming back and forth to whatever center they're going to check the labs, getting the infusions. And they pay that price mainly over the first month or 2 of treatment. After that, it gets really straightforward and they're able to get their therapy and stop around a year later. So it's after you go through that period, you still have some toxicity. You have some cytopenias, sometimes low counts, or sometimes you have to use some growth factors to keep the counts up, but it's unusual to require transfusions and things like that. Infection risk is not much different compared to the BTK inhibitors. So it's much more of a problem in the beginning, then you get your benefits later on, but that beginning can be quite challenging for many patients. What is becoming very interesting is that what we had was 2 very separate options are more and more starting to merge. And this conversation of continuous versus intermittent therapy or abbreviated versus continuous is starting to get more and more complex. So we had, for example, a study that evaluated, it was not only that, but on that study, we used acalabrutinib, one of the BTK inhibitors, and one of the arms of the study had obinutuzumab, the antibody that we add to venetoclax, to acalabrutinib. And on this study now has been followed for many, many years. The patients that received obinutuzumab with acalabrutinib actually had better disease control years later, with only 6 additional months or 6 months of the combined therapy. So you give the infusion, the typical schedule, in the first 6 months as you're taking the acalabrutinib, the BTK inhibitor, and just because of those initial 6 months, you have improved disease control 5, 6, 7 years later. So some are starting to revisit the idea that maybe I can actually give these antibodies with both BTK inhibitors and the venetoclax. But still, we're not talking about a finite therapy. We're still talking about the idea of adding the antibody to the BTK inhibitor just allowing for better disease control. So you're kind of stuck with that idea that you have to do the bigger commitment of coming for the infusions every month in the beginning. Maybe you have better disease control in the end, but kind of defeats the purpose of just getting the BTK inhibitor that is very easy and very straightforward. But you start to see that maybe there are some patients that might benefit. And in fact, what you're starting to see is that sometimes by adding the infusion at the beginning, actually allows for deeper disease control that may allow for the interruption of the pills around 2-3 years later. So again, meeting in the middle without the big commitment of the venetoclax, but still some commitment from the infusion, but kind of a little bit of an easier process, allowing you to eventually stop the BTK inhibitor. It's not the standard at all, but we're starting to see that trend. And another trend that is very important is really combinations that are using both the BTK inhibitor and the BCL2 inhibitor. So one of the drugs, ibrutinib, acalabrutinib, zanubrutinib, combined with venetoclax. This actually is a combination that is approved in Europe, approved in South America, still not approved in the US, but it's on the NCCN guidelines. So you're able to get that combination in many different settings. So when we're doing that, we're really using two potent agents, allowing for deeper response and potentially stopping. And by combining two drugs, two pills, you may be able to do a IV-free option, so a pure pill option that allows you to stop the therapy, but you still have, obviously, the little caveats from combining those two drugs. You may ask, two are great, why don't we do three? So there are combinations using the three of them. AVO, acalabrutinib, venetoclax, obinutuzumab, bovin, zanubrutinib, obinutuzumab, venetoclax. So we have these combinations, but what we're seeing is that probably the Goldilocks is true. When you add a third drug, you add a little bit more of benefit, a little bit more of response, but more toxicity. But maybe there might be some settings that these triplets might be better than doublets. So if we go back a little bit, the initial conversation that you're still going to have today as standard of care is that you want an easier way in that is going to give a great chance of controlling your disease, and maintaining this disease control will require you to remain on therapy? Or are you willing to give a little bit more of your time in the beginning, require a little bit more visits to the lab, to the infusion center in the beginning, but allow you to potentially interrupt your therapy early on? We're talking about, in general, very general terms, because we didn't really talk about, obviously, some very critical details. And the details that help us decide between one or other option can be both from the patient themselves or from the disease. So from the patient themselves, obviously, you have the most obvious ones: social issues, whether you have transportation, don't have transportation, obviously that's very important, personal preference, but also the other medical problems. So some of the medical issues may be a bigger or smaller problem for these drugs, depending on the toxicity around on the side effects. So for example, patients who need a lot of blood thinners or something because of their hearts may still be able to use a BTK inhibitor, but something that you have to be a little more cautious with it. Patients who have kidney dysfunction are actually fine to get venetoclax. The original study actually evaluated it on patients that had a suboptimal kidney function, but maybe a little bit of a bigger problem to do it. But then, in addition to that, we have genetic markers. As you know, whenever we decide to treat the disease, we will do molecular studies to really identify mutations or things that will guide us on therapy. Some of them are predictive. They can help us understand what will work better or not. Some are prognostic. Some will tell us what to expect in the long run. And today, we don't really have a lot of mutations that will really push you one way or another. Most mutations have activity by both classes of agents, BTK inhibitors and BCL2 inhibitors. But there are two special ones that we have to just be a little more cautious. And one is TP53 or 17p deletion. And the other one is the unmutated IGVH or IGHV, which is the immunoglobulin is really the kind of like the ID of your CLL cell. And it can be mutated, which actually, in this case, represents a more mature cell. These cells usually mutate to adjust to the antigens, to whatever is coming to invade your body, and they mutate to attack it back. So a mutated cell is a more mature cell, is an older cell. And in cancer, the more immature the cell, the more aggressive it is. So the unmutated IGVH represents a more immature cell and is usually a little more aggressive disease. So the unmutated IGVH and the 17p deleted patients, or the ones that have TP53 mutation, these mutations are properly addressed with both venetoclax, BCL2 inhibitors, or BTK inhibitors. But it seems that BTK inhibitors do a little bit better in those mutations. So some may prefer to have those agents as part of the regimen if those mutations are present. But if the decision is to not use a BTK inhibitor for whatever reason, venetoclax-based therapies will still have activity when those mutations are present. But you may just have a little bit of a shorter benefit from the drug compared to other patients that do not have those mutations. So when we're deciding to make a decision on treatment, when you decide that there is indication for therapy, you need to treat, and okay, what we're going to do. So you really would expect that the decision is made in a collaboration between the doctor and the patient, because a lot of what is going to decide is based on the patient's preferences, but it's really taking into consideration the disease behavior, mutations, features of the molecular features of the disease, other medical problems, and expectations as far as therapy is concerned. So it's really a very complex decision. The reality, thankfully, there's no right answer, and really the right answer is the answer that fits you best. So it doesn't feel like if we choose one, actually is going to impact too much we're going to do later on. So if we have issues with BTK inhibitors, yes, you're expected to have responsibility exposure to BCL2 inhibitors after, and the opposite is true as well. So in the long run, as of today, it seems that whatever option you choose first will not impact much what you're going to choose later on. But eventually, if these drugs stop working, we tend to then switch classes. And this is becoming a more and more complex conversation as we have more and more classes of agents becoming available. So we have a non-covalent BTK inhibitor called pirtobrutinib, which has activity even when these covalent BTK inhibitors don't work. We have a new class of agents that is emerging called BTK degraders. So both when covalent BTK inhibitors, non-covalent BTK inhibitors no longer work, BTK degraders appear to still have activity. So the basic principle behind it is that you may inhibit the receptor, and the receptor may become completely mute or dead. But that cascade that stays downstream from the receptor is still there. And it can serve as a scaffolding for other pathways to come and activate the cell. So the degrader really destroys that scaffolding and really inhibits that cascade of activation downstream. So it's a different mechanism that may work even when the inhibitors are no longer working. We have newer antibodies. So we have what is called bispecific antibodies. So antibodies that now have two arms are much more effective than the single arm of obinutuzumab or rituximab. We have CAR T cell therapy, cellular therapy, where we remove the lymphocytes, teach them to attack the disease, infuse them back. So today, what is happening is that it's really a marathon, and we just have to really be careful what we do today. Not too much because what is going to impact what is going to respond or not, but we have to be careful what we do today does not damage your body too much. You're going to have a hard time tolerating these drugs in the future. And one of the main drugs that we used to use a lot in CLL, bendamustine, fludarabine, we avoid them a lot today because they will impact the health of your good lymphocytes, which we may need for CAR T cell therapy, bispecific therapy in the future. So it's a very good time to treat this disease because we have so many options. Obviously, there is a lot to be improved. There's a lot to do, but certainly it's the more we understand about it and the more we know about these drugs, the better the combinations will be and the more successful we'll be treating them. So I'll stop here and I think we should have some questions.
Thank you so much for your presentation, Dr. Alencar. That was very insightful. Yeah, like you said, we'll go ahead and start with the discussion part of today's event. Share my screen again. As a reminder, you can ask a question or make a comment by typing it in the chat box or by raising your hand if you'd like to speak. If raising your hand once you're called on, you can then unmute yourself. So we did have a question come in during the presentation. All right, so Janet stated, I understood that the studies of early versus late treatment were based on chemoimmunotherapy and not on the new targeted drugs. Can you comment on the Evolve study that is testing the early versus late treatment start for high-risk patients?
So yes, thank you for that question. So that's absolutely correct that the initial studies were done with chlorambucil. So chlorambucil obviously is a drug that we don't use today anymore because it has very little activity. But we do have studies now that evaluate the same principle of treating patients when they don't have indication for therapy versus patients that have a clear indication. And one of these studies, yes, like Evolve, focus on high-risk patients, on patients that had high-risk mutations. And another study evaluated patients in general using both studies BTK inhibitors. And the data, with no surprise, brings us to the same spot. There's really no added benefit from treating the disease early. So we expose patients earlier to these agents that still have some toxicity. So the patients that were treated had a little bit more risk of bleeding, a little more arrhythmias, a little more complication, but without really improving long-term survival. So even with new agents, the standard remains to observe patients until they have indication for therapy.
Thank you for answering that, Dr. Alencar. Jen, I hope that answers your question. If you do have any other concerns, feel free to say them out loud or drop them in the chat. Okay, so we did have some pre-submitted patient questions as well that I would like to go over, Dr. Alencar. And while we're going through these, if anyone here attending live would like to just think of something, put it in the chat, you can. So one of them was, which is less expensive in the long run, fixed duration CLL medicines like venetoclax and obinutuzumab, or the continuous duration BTK inhibitors?
In the long run, the outcome is the same. So what we expect is that you just reach that point in a different way. So with the BTK inhibitors, you have very high response rate. And what happens is that approximately 30% of the patients eventually going to have problems with the therapy. Half of them, the issue is tolerability. So you may have to adjust therapy because of toxicities, prohibitive toxicities. Other patients may really develop resistance, so require adjustment in therapy. While with the BCL2 inhibitors, you have the disease treated, stop, eventually to require therapy again. Depending on the length of time until the second treatment, sometimes you can re-expose to venetoclax. We're starting now to see patients that were treated with venetoclax-based therapies in first line based on CLL14 early on and seeing that they have response again. May not be as deep as they had in the first time, but eventually, so you might not have the great response, and you may have to switch classes completely. So just on the long run, the disease control is pretty much the same, but how you get there, either with a very prolonged treatment, then adjust, either through another BTK inhibitor, so you go like from acalabrutinib to pirtobrutinib, and you just continue the same class, and some doctors like to get everything out of that class before switching agents. Some doctors prefer to switch classes, so then you are addressing the disease a little bit in a different way. So alternating a BTK inhibitor with a BCL2 inhibitor and then another BTK inhibitor. But on the long run, there's really no clear winner of which one you should start first. And I see the Carolyn question on the chat with the BTK inhibitors. It wasn't clear if you said that at a certain point your white blood cells build up resistance to the drug. So that's the thing. So yes, the expectation is that there is a proportion of patients that will develop resistance over time. So we have patients on ibrutinib even for more than 10 years now and still maintaining excellent disease control. But yes, you see some patients that are progressing through these agents mainly through development of resistant mutations. And this is one of the paths of hypothesis of research today that maybe what we can do is try to interrupt therapy once in a while and try to see if by interrupting, giving the cells some room, you may actually decrease this pressure to develop resistance. It's not the standard, it's being evaluated, but there is a hypothesis that by the interruption of therapy may actually decrease the development of mutations. But one of the ways the patients need to switch therapies is development of mutations.
That's good to know. Thank you for answering that question. And then along with do you know if there's a difference cost-wise for like eventually patients likely will end up doing both classes, like if they start with venetoclax and obinutuzumab and later choose a BTK inhibitor long-term. But starting out, do you know if there's a cost difference if one is less expensive than the other?
Cost is extremely variable because it varies incredibly with patients' insurances. Each insurance has different agreements with pharmacies and so how much the insurance pays, how much the patient pays varies incredibly. So it's very, very difficult to talk about the cost just because there's so many variables and how much your insurance will pay for each visit for the infusion. And then you're going to start adding if you're going to do venetoclax, you're probably going to see the doctor more frequently in the beginning because they're checking labs more frequently. So you're having labs added. On the other hand, the BTK inhibitor exposed to the drug for longer. So it is extremely complex. It's not simply the cost of the drugs, but everything that goes around them. And even whatever goes around them or the drugs themselves, the costs vary incredibly patient by patient because of each different insurance coverage. So when we are discussing therapy, we start with the biology. We start with the indications and with what fits best. But yes, a lot of times then when we go to the next step, which is getting the insurance approval, we may have some roadblocks. And it may be an alternative, whether it's the insurance, the payer has a preference for acalabrutinib versus zanubrutinib or something as minor like that, or really having a prohibitive copayment with the infusions and you prefer something that is non-infusion. So I prefer to first try to see what fits medically best, but then potentially make adjustments depending on insurance limitations.
That makes sense. Thank you for answering that. Okay. Another pre-submitted patient question that we have is CAR T cell therapy considered a fixed duration medicine?
So CAR T is a fixed duration, right? You just get a single infusion of treatment and that may allow for prolonged disease control. So yes, if you're going to, if CAR T is not a continuous therapy that you have to get many infusions, it's a one-time deal. You go collect the cells, there's a processing time to get the cells prepared. Once the cells are shipped back, you receive the infusion of the cells, and that's your treatment. It's a one-time deal.
Thank you for answering that. That's good to know. And okay, another pre-submitted question. This patient is asking, if I live far away from a treatment center, what therapy would you recommend for my CLL when I need to start treatment?
The distance to the center itself is not really the main problem. So obviously, if you're far from the center, you might have a harder time if you decide to use a regimen that includes obinutuzumab. Remember, you're going to have frequent infusions in the beginning. So obinutuzumab schedule, you have day 1 and day 2. So let's say you start on a Monday. You have Monday, Tuesday, Monday, 3 weeks in a row. Then you rest 1 week. and you have a Monday every 4 weeks, 5 more times. So you're going to go to the cancer center or the office or whatever you're going to get the infusion 9 times or so in a period of 6 months. So it may be far enough that going weekly is too complicated. Or maybe it's not, and you can just arrange that you have the infusion in the beginning and then not have to worry about that much. But then comes that issue with the labs. In the beginning, as you're getting venetoclax, on the first few weeks, you're going to have to get labs very frequently. Pretty much you go in the morning, check your labs. Labs are good. You take your pills, repeat your labs 8 hours later. Then the following morning, repeat your labs again. So it's not only that you need to be close to a place where you can draw the blood, but also an important factor is that the results have to get to your doctor fast enough that the doctor can review them and act on them. So if you live far enough that you're going to go to a blood center where you're going to draw your blood and the results are going to come back in a week, it's not going to be feasible to do venetoclax in the beginning, for example. So it's not just the distance, but what is available for you as far as the lab, or if you're able to just drive the distance to get the infusion. So it's very important that you discuss all these important pieces with the doctor when making a decision, and not simply the distance.
That's good to know. Thank you for elaborating on all of the different factors. That's definitely important to have those conversations so patients can be aware. And then a side note, if anyone does, we can include in the follow-up resources or as well on our website for those that do need to travel to treatment centers. And I know that that can sometimes add on the finances if you don't live close, but you are starting therapy. We have a financial resources page for patients and caregivers that goes over things such as housing costs. So separate topic, but just a shout out if anyone would like further information on that. All right, thank you, Dr. Alencar. The last pre-submitted question we had here, and I know that you've gone over a lot of these in your presentation, so thank you so much for re-summarizing them, is obinutuzumab or Gazyva considered a fixed duration therapy?
So it's not the drug, is how you give it, right? So obinutuzumab in general is given for 6 cycles in CLL. So you usually combine obinutuzumab with venetoclax, and when you do that, you will give obinutuzumab for the 6 months and the venetoclax for 12 cycles. So, and then you stop. So that is a finite therapy, right? You have a period where you stop. But for example, if you add obinutuzumab or Gazyva to acalabrutinib, which is done in some settings, is a continuous therapy because you get the 6 months of obinutuzumab, but you're going to continue getting the acalabrutinib theoretically indefinitely. So it's more of how you combine these drugs than really the drug themselves. The same thing for ibrutinib and venetoclax, even, for example, something that we don't use too frequently in the US, but it's done very routinely in other countries. So in this regimen, for example, from the study Captivate, the combination was given for a finite period of time. So even though you're using a BTK inhibitor, you're using for a finite period of time.
That makes a lot of sense. Thank you for elaborating on that. And that provides clarity that I'm sure will answer the question that they were asking there. Perfect. Okay, let me go ahead and just double check the chat. All right, so Carolyn is asking, are there any issues with starting one type of therapy and then switching to another based on your specific health issues?
No, not at all. Sorry, I just got it's not really a problem. A lot of times we don't know what to expect from therapy. So you may start with something and then have to adjust because of tolerability, because of organ function. So no, it's not really a problem. It's part of treating these diseases that you give the therapy and then you have to adjust based on how you tolerate.
Thank you for your answer there. Okay, I'm not seeing any other questions in the chat, and let me just double check. Okay, we're not seeing raised hands. Well, wonderful. We will go ahead and wrap up then. Thank you so much for everyone for participating. Dr. Alencar, for your presentation. Let me make sure that you can still see my screen. Okay, great. Okay, so that is all the time that we have for our discussion. I do want to inform everyone of some free resources available to you. So one of these is called HealthTree Care Hub. We invite you to securely connect your medical records to track your CLL labs in one place and become a Cure contributor to accelerate CLL research by participating in surveys, find clinical trials, and side effect solutions. So access your free HealthTree Cure Hub by visiting the link at the bottom of this slide. I'd also like to mention when our next CLL webinars will take place. Next week on June 25th, you're invited to learn from Dr. Carrie Rogers about relapsed refractory CLL treatment options. On July 30th, we'll have Dr. Nitin Jain, who will share how often patients need common CLL tests. To register for one or more of these events, please visit the link at the bottom of this slide. I want to again take a moment to thank our HealthTree community for CLL sponsors, without whom this event would not be possible, AbbVie and Genentech. And thank you everyone for helping us build a strong HealthTree community for CLL. I appreciate you all. I hope to see each of you again soon. Please don't hesitate to reach out if you have any questions about HealthTree or upcoming events, and you can reach out to the email found on this slide, cll@healthtree.org. Thank you so much, and I hope you have a great rest of your day.